Hello.
I think I'm going to start now. From now, can everyone mute their audio so that I can be audible to everyone without any issues? I'm going to mute everyone. At the end of the session, I think I can give you 15 to 20 minutes so that we can discuss whatever the questions uh, pertaining to this topic. And regarding the exams, I'll give you some tips uh, at the end of the session. Those who are interested can question me. Now the present scenario is it is both same. JCSFE and JCIE doesn't have any difference at all. And so we'll start. And then if there is anyone who's going to join, please text in the WhatsApp group so that I can allow them join the session. All right. So today's topic is a hot topic. I know that this is a hot topic in any FRCS exam, part one, part two. So what I'm going to discuss is what is more relevant in UK practice and more relevant towards the NICE guidelines. Different part of the world have different management guidelines and trust protocols, trust hospital protocols, guidelines, and different surgeons will have different ways of managing emergencies. What is expected out of the exams? What the guideline says, and what is needed for the exam is going to be discussed. At the end of the session, you can ask anything, whatever the doubts, whatever the queries. I'll put it in the end of the question, and you can put it in the chat box as well. I'll have a look at the end of the session, and then we can proceed further. So, colonic emergencies. Coming on to the topic, colonic emergencies. There are around 5 types of emergencies which we encounter as a colonic emergencies. One is obstruction or colonic obstruction or large bowel obstruction, and colitis. It can be ulcerative colitis or inflammatory bowel disease, and toxic colitis. It can be infective toxic colitis. Perforation can be iatrogenic, or it can be a disease process, probably because of malignancy, or it could be because of inflammatory perforation. Hemorrhage and ischemic colitis. Hemorrhage can be because of, again, inflammatory and infective, can be because of iatrogenic, other lesions. Ischemia of the colon, or ischemic colitis. So these are the broad emergencies, colonic emergencies. And the most common emergencies which we come across during the practice is obstruction, and again, neoplastic obstruction, or colonic obstruction, or large bowel obstruction due to malignancy. These are the causes of colonic obstruction or large bowel obstruction. Most common is neoplasm. 20 to 25% of the large bowel obstruction is because of uh, colonic malignancies. And most commonly, again, left-sided 25% or 30%, and right-sided obstruction are again 25 to 30%. So the most common is on the left side, and the other causes of obstruction are valvulus, chronic diverticulitis, stricturous diverticulitis, pseudo obstruction, hernia, stricture, fecal impaction. Fecal impaction is again most common during the seniority or in the elderly age group. Inflammatory bowel disease causing colonic obstruction is extremely rare, and interception. Again, interception in terms of rectal prolapse is a type of interception which we think of. And endometriosis, adhesions are more common in small bowel rather than in large bowel. And ischemic obstruction. These are the causes. These are the causes which is mentioned in the uh, uh, books. And regarding the Neoplastic obstruction, as I said, neoplastic obstruction occupies the most common emergencies. Around 20% of the colonic cancers present as neoplastic obstruction in the emergencies, and nearly 30% will have hepatic metastasis at the time of surgery. So 20% most common, 20% of the emergencies, large bowel emergencies, could be malignant. And out of this 20%, 30% may have hepatic metastasis at the time of surgery. And regarding the symptoms, large bowel obstruction, the most important thing, I'm going to draw something on the sides of the the screen. If a patient who comes with large bowel obstruction, sorry guys, if there is some noise, I have to remove the people. Sorry, it should not be a disturbance to other people. Uh, going on to the topics. Okay, regarding the symptoms, so all the I think these are going to be a common scenario. Any patient who comes in with abdominal distension, abdominal pain, has not passed opened his bowel, or has not passed stool, and nausea, vomiting are not more common symptoms in large bowel obstruction. The most common symptoms of large bowel obstruction are altered bowel habits in terms of constipation or obstipation, and abdominal distension, obstipation, and absence of passing flatus. These are the most common symptoms. When the patient presents with these symptoms with weight loss, then there is going to be a sinister problem like malignancy. And if there is no weight loss, you have to think of any benign problems. And nausea and vomiting. Nausea and vomiting is not a main symptom of large bowel obstruction. The reason is because the ileocecal wall acts as the barrier, and it becomes a closed loop obstruction. Consider the large bowel anatomy. If this is the large bowel anatomy, and you have an ileocecal wall, if it is competent, and there is an obstruction at the level of the left colon, and this part of the bowel acts as a closed loop. So it is a closed loop, and it becomes an emergency. And when there is obstruction at the level of the left colon, and when there is a competent ileocecal wall, there is no need for NG tube here. And the NG tube is not going to help the patient at all. And also this acts as a closed loop, and there is a high chances of we may lose the whole of the large bowel when the obstruction is worsening on a daily basis, and when we are not intervening as early as possible. So this is more important concept when, and this is going to help us in the management plan as well. Regarding the initial investigations of large bowel obstruction due to malignancy, everyone knows, make sure that these patients are managed as per the CRISP protocol, or CRISP protocol. I think there is a RCS England course which is run by RCS England, says CRISP. So try to learn about that. That will be assessed in the exams extremely in depth. And the initial management of these large bowel obstruction due to neoplasm, try to resuscitate the patient, make sure that the patient has got all sepsis 6 protocol is done, and then check the lactate, then go ahead for CT scan. CT scan is the best investigation to make your diagnosis. And then once the CT scan says it's a large bowel obstruction, the options here are colonic stents, surgery, and what are the types of surgery. So what is the role of colonic stents? When the patients are elderly, not fit for any procedure, the plan will be for going for a colonic stents. What is the evidence about the colonic stents? The evidence says that it doesn't have any big difference in emergency surgery versus colonic stent. However, when the patient needs an elective procedure, when it can be bridged, when the elective procedure can be planned, that is the chance of colonic stents. And few of the trusts follows colonic stents and few of the trusts doesn't follow the colonic stents. However, the disadvantage of the colonic stents is when the patient is planned for any palliative therapy with bevacizumab. Bevacizumab is a monoclonal antibody which is used in the palliative setting in the colonic malignancies. When this medicine is used, there is high chances of perforation with the stents. So if at all, if they are not going to use bevacizumab, then colonic stents can be used as a bridge to surgery. And it all depends on and there is no evidence which suggests colonic stents are superior for surgery. The other options of surgery, there are options of surgery here when there is a left-sided tumor. There's a left-sided tumor. The options are are we going to plan for a left hemicolectomy or a subtotal colectomy? It all depends on the cecal diameter. The cecal diameter is 12 centimeter, and if cecum is not healthy, you have to go ahead for a subtotal colectomy. And if there is a proximal dilatation, extremely proximal dilatation, then the patient should have a Hartmann's kind of procedure. And if the patient has got normal diameter proximal to the stricture, then there is a chance for resection and anastomosis. Usually they go for a sigmoid colectomy with the proximal diversion because of the chronicity of the thing. And if there is a rectal tumor, don't try to operate, don't try to remove the rectal tumor, try to extrudize the proximal bowel as a loop colostomy. So as a loop colostomy, the proximal bowel. So different types of management in a neoplastic colonic malignancy. Sigmoid colon, if there is a neoplastic obstruction in the sigmoid colon, sigmoid colectomy with a Hartmann's type ostomy. And if there is a rectal tumor, do a loop colostomy of the sigmoid. And if the cecal diameter is extremely high due to the emergency situation, due to the closed loop situation, if there is an unhealthy cecum, then you have to go ahead for a even subtotal colectomy in a rare situation. So these are the types of surgery which is proposed, which can be done for so it all depends on the situation. You have to assess the scenario before we answer the question for this kind of obstruction. And regarding the intraoperative techniques, how are you going to decompress the bowel? The decompression of the large bowel can be three types. There are plenty of types. You can use the appendix, you can remove the appendix, and you can remove the appendix, and you can do a colonic wash. Colonic wash can be done either by needle decompression or can do a intraoperative colonic lavage or decompression, and needle suctioning the stool. So these are the three ways. These will not be assessed in the exams. Usually you have to know it by. So needle decompression of the colon intraoperatively, suction, and intraoperative colonic wash or colonic decompression. So these are so basically, if we go for a neoplastic obstruction, most common 25% chances of neoplastic obstruction as an emergency, and any elderly male or female, most common again it's left-sided. And then regarding colonic stents, it will be your knowledge will be assessed in the colonic stents. Think about in which case we will use the colonic stent and the types of surgeries during in the obstruction. So if it is a left-sided hepatic flexure tumor, you can either go for a splenic flexure tumor. If there is a splenic flexure tumor, either you can go for a left hemicolectomy or a extended right hemicolectomy. Again, you have to assess the situation. If the cecum is not good, if the cecum is distended, not healthy, then you have to go for an extended right hemicolectomy. And if the cecum is fine and it is not an emergency, still you have the option of going for a selective sigmoid left hemicolectomy or segmental colectomy as well. So the next most common topic which is assessed in the colonic emergency is diverticulitis, and everyone knows that regarding diverticular diseases, diverticular disease is another most common causes of. Just a second, sorry. Right. Regarding diverticulitis, again, the most important topic in the exam which will be assessed is again colonic diverticulitis. Diverticulitis is inflammation of diverticulum. Again, most common in the sigmoid region. Sigmoid diverticulitis is more common. Most common age group, elderly age group. The incidence of diverticulitis increases after 40 years, and at the age of 60 you get at least 50%. At the age of 70 you get at least 60 to 70% of the population have colonic diverticulosis. It doesn't mean that all will have diverticulitis. The diverticulosis is more common in the elderly age group, and the incidence increases as the age increases. And the complications of diverticulosis is diverticulitis or inflammation. It can go for perforation, abscess, and stricture and fistula. So these are the complications of diverticulitis. And 80% of the time, so I'll go for this next. So how are you going to, symptoms wise, the most common symptom is signs of inflammation, left iliac fossa tenderness, pain, vomiting, fever, altered bowel habits, bleeding per rectum, or blood in the stool. So these are the more common presentation of the diverticulitis. Sometimes it can be obstipation or constipation as well. So with these things, examination and then proceed for investigation. You'll have raised inflammatory markers, raised white cells with raised inflammatory markers. The patients can present with sepsis. And regarding the investigation of choice, the best investigation of choice is again CT abdomen pelvis. It gives you more information about the types of complications as well. Like it can say about the fat standing with inflamed sigmoid colon, with the inflamed colonic colon, which says diverticulitis. And if there is a small perforation, the CTs can give you the type of diverticulitis. So we know about types of diverticulitis, complications of types of. I will come into this later. Regarding the obstruction caused by diverticulitis, it is rare for an acute inflammatory diverticulitis to cause obstruction of the large bowel. It is a long-term chronic process, and it mostly doesn't present in an emergency. Most of the time, it is a semi-elective kind of thing. The reason for obstruction in diverticulitis is chronic inflammation causing diverticular stricture. In these patients, stents have a very good role. So make sure that if the patient comes in with diverticular disease, diverticular stricture, presenting in obstruction in emergency, there is a extremely high role of stents. in these patients. So patients are planned for colonic stents in diverticular obstruction, diverticular stricture and obstruction, and then we can proceed for elective sigmoid diverticulectomy with a primary anastomosis, sigmoid diverticulectomy with a primary anastomosis, or Hartmann's type uh, resection, Hartmann's type sigmoid colectomy. The next most common cause of so operative approaches include, so there's again, this is more important trial which I have to mention here, ladies trial, which gives you the option whether you going to do a laparoscopic washout of the divertic. I'll explain this about this thing when I discuss about the inflammatory causes of inflammatory emergencies. The next is most common cause of colonic emergency again is a sigmoid volvulus. So I don't want to go into what is the reason, what is sigmoid volvulus. We are not into what into the business of what is sigmoid volvulus. The most primary cause and secondary causes, make sure that the primary cause is long, lengthy sigmoid mesocolon with a loaded sigmoid, narrow attachment of the sigmoid mesocolon. These are the primary causes. And the secondary causes of sigmoid volvulus, it can be because of Hirschsprung disease, Chagas disease, trypanosoma cruzi. So these are the other secondary causes. And sigmoid volvulus is, again, it has got increased incidence during the pregnancy. Regarding the symptoms-wise, the large bowel symptoms, as I said, you not opening bowel, altered bowel habits, constipation in sigmoid volvulus, obstipation, abdominal distension, abdominal pain. Investigations again, resuscitate the patient as per the CRISP protocol. Go ahead for a CT abdominal pelvis. The initial investigation in sigmoid volvulus, usually it is picked up by the X-ray abdomen. We are out of the era of X-ray nowadays, but still, most of the time the X-ray knowledge is tested in the exam as well. So go for a X-ray abdomen, and sigmoid volvulus is diagnosed with a coffee bean appearance of the dilated large bowel, which starts from the left iliac fossa. I'll show a few X-rays at the end of the session so that it will be helpful as well. They call it as either a coffee bean sign or omega loop sign. So regarding the management, I would like to stress on the management. What are the things? So elderly patient, recurrent episodes are more common, and start with, once you diagnose it as a sigmoid volvulus, start the management line as with rectal tube. This rectal tube is passed, or flatus tube is placed only if the patient is not peritonitic, if there is no signs of any peritonism, tenderness, no guarding, no rigidity. If the patient shows any signs of volvulus with perforation, there is no role for flatus tube or rectal tube. And if the patient is peritonitic, then the option is laparotomy and sigmoid volvulus sigmoidectomy without derotating the volvulus. Once you get into the abdomen, don't derotate the volvulus, just take off the sigmoid gangrenous bit of the sigmoid, and then proximal ostomy or end colostomy, left end colostomy is the option. Don't mention in the exam that you're going to do a anastomosis, sigmoid colocolic anastomosis, or primary anastomosis in a patient who had a sigmoid colectomy. The reason why they say is there is a discrepancy of the proximal bowel and the distal bowel, luminal discrepancy, and that is not favorable for a primary anastomosis. So the best option, or best on a daily basis across the world, I know there are plenty of, I have personally done sigmoid end-to-end anastomosis, but exam point of view, the answer will be proximal diversion when you have a sigmoid volvulus after the sigmoid colectomy, if it is an operative management. Okay, when it is going to be a rectal tube or flatus tube which is placed, how long we are going to place it is going to be there for 24 to 48 hours, because the recurrence rate is extremely high when you just pass it and deflate it, and then if you remove it. So place the rectal tube for at least 48 hours, and then take it, remove it. Primary, either you go for a immediate sigmoidectomy laparoscopically or open, and discharge the patient after the surgery. Assess the patient for surgery at the time of the admission. Once the patient gets relieved of acute episode with the rectal tube or with the flatus tube, emergency surgery, the same admission, ostomy, and you can plan for a primary anastomosis if the patient is, if the proximal lumen is fine, and then discharge the patient in the same sitting. Next is the cecal valvulus. Cecal valvulus is again extremely tested in the exams. Cecal valvulus, again, it's a type of large bowel obstruction. The reason for cecal valvulus is if there is a intraperitoneal cecum. Cecum is partially retroperitoneal, partially intraperitoneal. So if this, just a second, sorry. So if this cecum is partially retroperitoneal, partially intraperitoneal, so the intraperitoneal cecum is more prone for cecal valvulus. Again, it can happen at any age. It doesn't mean that it has to happen in the elderly age group. Okay, any freely mobile cecum can go for valvulus. Usually, it is either a clockwise, anti-clockwise. The old rule of clockwise, anti-clockwise rotation of valvulus is no more considered. There's no study which says that cecal valvulus is anti-clockwise, clockwise, and there's nothing like that nowadays. Regarding symptoms, again, it follows the same symptoms like other large bowel obstruction. Investigation-wise, you do all full blood count, lactate to make sure that it is not perforated, patient is not septic, and CT scan is the best investigation to proceed further. And then management, when it comes to management, there is no role for colonoscopic decompression or sigmoidoscopy or anything. Once the cecal valvulus is diagnosed, it is right hemicolectomy is the treatment of choice, and there is no role for cecopexy or any other management. Once the cecal valvulus is diagnosed, the treatment is right hemicolectomy, or you can say that you can just do a segmental cecectomy or ileocolic anastomosis or limited right hemicolectomy, whatever, but there's no role for cecopexy or cecostomy tube. And then comes the cecal bascule. Cecal bascule is anteroposterior valvulus. It is not rotation of the mesentery, it is the rotation in the axis with the cecum itself. It's anteroposterior rotation. And the treatment again is the same, selective cecectomy or limited right hemicolectomy. Then comes then it's the acute colonic pseudo-obstruction, it's called as Ogilvie syndrome or pseudo-obstruction. And there is a postulated theory. The reason for the acute colonic pseudo-obstruction, they say it could be because of parasympathetic inhibition in the large bowel. The most important clinching point when we have a colonic pseudo-obstruction is your cecal diameter. How are you going to, what are the causes of colonic pseudo-obstruction? I'm not going to get into this thing. Colonic pseudo-obstruction can be n number of reasons, can be because of medical problems, can be because of electrolyte imbalances, especially hypokalemia, hyponatremia, and it can be because of opioids, morphine, overdosage of morphine, can be anesthetic, fluid overload, not fluid overload, can be because of opioids. So n number of reasons for acute pseudo-obstruction. And the reasons, the pathophysiology behind could be the postulated as parasympathetic inhibition. The most important thing which we have to think about is the cecal diameter when it comes to the colonic pseudo-obstruction. If the cecal diameter is 12 centimeter, there is a high chances of perforation and 40% chances of mortality. And make sure that once when we see a patient with colonic pseudo-obstruction, the most important thing which we have to check is cecal diameter. Again, the investigation wise CT scan is going to prove you that there is no mechanical obstruction which is causing this problem. CT is going to help you out to rule out other mechanical causes. How are you going to manage the pseudo obstruction? The most important thing in the pseudo obstruction is rule out all the causes of pseudo obstruction, like correction of electrolytes, make sure that the bowel gets rested, and NG tube is extremely important in colonic pseudo obstruction, because it is not just the it is not going to be a closed loop obstruction during a colonic pseudo obstruction. It's going to be an open loop obstruction. So what is closed loop is, as I said, when the ileocecal wall is competent, then it becomes a closed loop. If the ileocecal wall is not competent, the content of the colon and the content of the ileum is going to be mutually moving in and out of the small bowel and large bowel. So when the ileocecal wall is not competent, whatever the content in the colon is going to go backflow into the small intestine, and when you put in an NG, it can get out of the bowel lumen through the NG. And so, as I said, once the cecal diameter is greater than 12 centimeter, the mortality and the morbidity increases up to 40%. Management, NG tube, yes, no, if it is a closed loop, and if it is an open loop, if the ileocecal wall is incompetent, yes, it is going to help. Most important thing is make sure that the patient does not get any laxative, because it worsens the situation, and try to manage the opioids, stop all the opioids, and correct the electrolytes, correct the causes of the colonic pseudo obstruction. The next most important step after you correct, every step has to be monitored every 12 to 24 hours. Once in 12 to 24 hours, if there is no resolution of symptoms of colonic obstruction, escalate the management plan. Correct all the electrolytes, stop all the opioids, make sure that all these things are corrected. Still is not improving, then you can give a dose of neostigmine. But the problem with neostigmine is it can cause bradycardia, bronchospasm, hypotension, and asystole. So most of the time, if you are planning for a neostigmine, then the patients will be managed in either high dependency unit or in the ITU setup, because the patient needs to be cardiac status has to be monitored on a regular basis. And then the next escalation plan is the patient gets correct, electrolytes gets corrected. You give us neostigmine, and still it is not settling down. Then you can do a colonoscopic decompression. When we talk about colonoscopic, just a second. When you talk about colonoscopic decompression, it is going to be done by an expert colonoscopist or endoscopist with a less inflation of the air, and suck as much as air out. And the colonoscopy has to reach up to the hepatic flexure, and you place a long flatus tube up to the hepatic flexure. That is the aim of the colonoscopic decompression in a colonic pseudo obstruction. And then still, if the patient is not settling down even after the colonoscopic decompression, then the options are here are check for the cecal diameter. Is this settling down? The role of cecostomy or tube cecostomy, there is no advantage. There is no evidence saying that cecostomy is helping. Sometimes there are few areas where we do under local anesthesia, we do a cecostomy, but it is not helpful. It doesn't give any improvement in colonic pseudo-obstruction. The best way next is to go for a subtotal colectomy if the patient is not responding to all these management. Usually, it is extremely rare for a patient to have a subtotal colectomy or a colectomy in a patient who has pseudo obstruction or colonic pseudo obstruction of Ogilvie syndrome. This is about, and once the patient is settling down, then we can start the patient on PEG or polyethylene glycol, uh, which may increases the sustained response rate of therapeutic intervention. Whatever the intervention which we do, once it starts kickstarting the resolution of symptoms, then there is a role of PEG. But I don't think this part is a controversial thing. They won't be tested in the exams. So this is the I don't know whether this is obviously visible or not, and this is the management algorithm. When you have a acute colonic distension, check for the ischemia or perforation of cecal valvulus. Make sure that the patient is not peritonitic. If the patient is not peritonitic, and if the patient doesn't have any mechanical obstruction, then you diagnose this as a pseudo obstruction. Once the pseudo obstruction is confirmed, make sure that if the ileocecal valve is competent, there's no role for NG tube. If the ileocecal valve is incompetent, or if the content is, if it is overall small bowel and a large bowel pseudo obstruction, or a palatic ileus with a pseudo obstruction, then there is a role for NG tube, and rectal tube can be placed. High rectal tube should be placed up to the level of the hepatic flexure. Avoid medications which triggers all these things, especially opioid analgesics. Correct the electrolytes, correct the fluids, and this is the guide. This is the flow chart which is given in the BSG guidelines, 2019. I think it is 2009. I'm not sure, but it is there in the BSG guidelines. So treat the reversible causes. Once if it is successful, you monitor the patient, and if it is not successful, again go for the escalation of the plan, neostigmine. Even if the neostigmine is not helping you out, then there is a role for colonoscopic decompression. If the colonoscopic decompression is successful, consider PEG administration. And if the colonoscopic decompression is not responsive, then there's no other go. You have to go for a surgery. Percutaneous colostomy or tube cecostomy doesn't have any evidence to say that that is helpful. It should be either a sigmoid colectomy, septal colectomy, or a partial colectomy. Right. Regarding the next part of the still till now we saw the obstructive colonic obstructions. Now next we will go into the inflammatory colonic emergencies. So inflammatory colonic emergencies, the most common is toxic colitis or megacolon. Again, toxic colitis or megacolon, the most two important causes of toxic colitis is inflammatory bowel disease, ulcerative colitis causing toxic colitis. The other few other causes of toxic colitis are C. diff colitis, and other inflammatory causes can be a number of causes: Salmonella, Campylobacter, sometimes other causes like Cryptococcus, immunodeficiency. I'm not going to go into this thing. So how are you going to diagnose a toxic colitis? Again, symptoms: abdominal pain, severe peritonism, raised inflammatory markers. So there is a criteria, nice guidelines. There's a criteria called as Jalan criteria, which has given the how to diagnose a colitis, how to diagnose a toxic colitis. It does not correlate with the ulcerative colitis True-Love-Witz criteria. This is something for toxic colitis, and that is for ulcerative colitis. This is actually a Jalan's criteria for toxic colitis. Make sure that you don't confuse this with the True-Love-Witz criteria for ulcerative colitis. This is for any toxicolitis that is exclusively for the ulcerative colitis. Regarding this criteria, you should have a radiological evidence of 6 centimeter of transverse colon. Transverse colon diameter should be greater than equal to 6 centimeter, and any 3 of the following: temperature greater than 38 degree, heart rate greater than 120 beats per minute, and neutrophilic leukocytosis, anemia. If any 3 of these are present, then it is a severe toxic colitis. It's a toxic colitis, and even if it is one of the symptoms should be present, like dehydration, altered sensorium, electrolyte imbalance, and hypotension. So make sure that these criteria fit into it. The colonic diameter greater than 6 centimeter is not a hard and fast rule. Make sure that this is not going to make a big difference. If the patient is satisfying the other symptoms, like 3 of the following, like temperature, heart rate, neutrophilic leukocytosis, with any of the altered sensory, dehydration, with dilated dilated large bowel, then still this can be a toxic colitis. So don't have a fixed criteria that the colon is not dilated to up to 6 centimeter, even if it is 5.5 centimeter with all these symptoms, still it is a toxic colitis. And these are the causes of the toxic megacolon. And I think even the diabetes and immunosuppression, Kaposi's sarcoma has been also been mentioned. And symptoms, I said you about the symptoms. Investigation, again, the CT colon is going to help you out. And in the CT colon, there can be a pneumatosis coli or gas particles in the walls of the colon, because if the gas particles are present in the wall of the colon, then it is a gangrenous bowel, so you have to take it off. And in the management, start any patient who comes in, elderly patient who comes in with loose stool, with dilated large bowel or dilated colon, consider this. The NICE guidelines says consider this as a C. diff colitis until proven otherwise. It takes at least 3 days for the C. diff colitis to be confirmed, but the NICE guidelines says that consider this as a C. diff colitis. Any patient, possible toxic colitis, possible dilatation of the colonic wall, colon, and consider this as C. diff colitis, and start the patient on management protocol guidelines as per the trust guidelines. You start the patient on antibiotics. Most common, the present guidelines says that vancomycin, metronidazole. Nothing wrong in starting the antibiotics, considering this as a C. diff colitis. And I'll deal with about the C. diff colitis sometime later. And regarding the management, antibiotics, resuscitate, sepsis 6, management, antibiotics, and steroids have a definite role in managing toxic colitis. And there are studies which says that aminosalicylic acid or mesalazine has got some role, and it is not continued just for an inflammatory process. If the patient is septic and not responding to these managements, the furthest escalation of plan is going for a subtotal colectomy or colectomy. Role of endoscopy in toxic colitis, again, should be done under the expert hands. Make sure that the lumen is filled or inflated with less amount of air, and then proceed further. Indications of emergency surgery. When the patient is not responding to your responding to your initial management, like antibiotics, IV fluids, resuscitative measures, and creeping white cells, creeping CRP, no response. Even CRP, if it is more than, usually we used to say 150, then it with the dilated colon, then still you can go ahead and treat the patient surgically. And then is Regarding the treatment, subtotal colectomy with an end ileostomy is the best treatment for toxicolitis. You bring out the end of the ileum as a end ileostomy and a mucus fistula. If these, most of the time, the inflammatory or toxicolitis is managed medically. If this patient is not settling down, then the only option is subtotal colectomy with the end ileostomy and a mucus fistula. And there's something called as neutropenic enterocolitis. The neutropenic enterocolitis is nothing but typhlitis. Usually they don't test you on this topic. Regarding the I think this is already dealt. So management improvement should be there in 24 to 72 hours in a toxicolitis. If you don't have any improvement in this management plan, then you have to proceed with the surgery. The next colonic emergency is perforation of the colon. It can be iatrogenic, it can be inflammatory, or it can be neoplastic. So the perforation of the colon can be inflammatory perforation, it can be malignant perforation, it can be what did I say? I forgot. So regarding the inflammatory perforation, the most common is again diverticulitis. They will be testing you with this in this topic. This is called as Hinchley's classification 1, 2, 3, 4. Can be easily remembered as 1 is pericolic, 2 is pelvic, 3 is purulent peritonitis, 4 is feculent peritonitis. 1 and 2 usually managed conservatively. 3 and 4 usually managed surgically. 1 and 2, in all these patients, you have to do a sepsis 6 and then go for antibiotics, broad spectrum antibiotics. 1 is usually managed with antibiotics. 2, depending on the size of the abscess. If you have the NICE guidelines says up to 3 centimeter, we can manage these patients with antibiotics. If the patient has got, say, more than 3 centimeter size of the abscess, it can be either pelvic abscess or it can be a pericolic abscess. Any diverticular abscess greater than 3 centimeter, if it is possible for a radiological drain, with a radiological drain. If the patient has, if it is not an accessible area by the radiological drain, then you have to go for a laparoscopic or open washout. So the management plan for 1 and 2, usually conservative, antibiotics, drain. 3 and 4, either you go for a laparoscopic sigmoid colectomy with a primary anastomosis or a Hartmann's type resection of the sigmoid colon with the Hartmann's procedure. So this is Hinchley's classification. This will be definitely assessed in the exams. So there are various trials which is going around, whether to go for a laparoscopic or open, Hartmann's dissection or primary anastomosis. Is it going to be a radiological drain? What are the ladies' trial and all these things? For the exam purpose, as I said, you 1 and 2 manage conservatively with antibiotics and radiological drain. 3 and 4 operation. The options will be usually Hartmann's, laparoscopic or open. It doesn't matter for the exams purpose. So what is stercoral perforation? Stercoral perforation is it is because of constipation. There is a hard fecal mass compressing the wall of the colon, which causes ulceration and perforation. Simple. Stercoral perforation is a chronic constipation or a hard stool. The hard stool, if this is the wall of the colon, and there is a hard stool here sitting inside the colon, and which compresses the wall of the colon, and this wall gets necrosed, gangrenous, and it perforates. And usually they used to say at least 1/3 of the circumference of the perioperatively, the stool has to come out through this thing, and it has to pop out like this. The stool has to pop out, and this is one of the severe form of perforation, colonic perforation, causing 4-quadrant fecal peritonitis. The reasons could be debility, megacolon, scleroderma, hypercalcemia, renal failure, transplantation. You can see the causes of stochastic perforation. All these patients will have a chronic constipation and intractable constipation. Manage criteria to say, I think these are the criteria to say it is stochastic perforation. Rounded ovoid antimesenteric perforation exceeding 1 centimeter, fecoloma, microscopic evidence with pressure necrosis, and exclusion of other causes of perforation. And the other causes of another most common cause of most common cause, it's another causes of colonic perforation is the chronoscopic perforation. 1 in 1,000 chances of colonic perforation, because the most common reasons for perforation, colonic perforations are iatrogenic. When there is again, sigmoid is the more common, where we negotiate the scope in. When we negotiate the scope in, the sigmoid is the more common area where we get the perforation. And the other reasons are polypectomies, large polypectomies, and what else? Perforation, inadvertent perforation of the colon. Most common site is again sigmoid colon. And treatment of colonoscopic perforation. Regarding the colonoscopic perforation, once the patient comes out of the colonoscope, if it is identified during the procedure, clip the if it is possible to clip the wound, you can just put 2 or 3 clips, provided the mucosa is approximated, and admit the patient. Don't discharge the patient. If you are in doubt, admit the patient. Definitely there will be free air inside the tummy because of perforation. It is not going to manage the patient. This is a prepared bowel, highly unlikely to have a fecal contamination inside the abdomen. And if the patient is not settling down with your conservative management, if signs of peritonism are getting, and ask if there is a polypectomy, you have to think about all these things in place, whether take the patient to theater, and primary repair or segmental colectomy is the management of these patients. Anastomotic leak, more common when there is a low anterior section, without a proximal diversion or proximal ileostomy. Usually because of the operative factors and the patient factors. If it is most common is operative factors like anastomotic, blood supply, length of this long duration of the surgery, left colon or low anastomosis or low anterior section has got high chances of anastomotic leak. The patients are diabetic, on immunosuppressants, anemic, other medical comorbids are the chances of high anastomotic leak. Regarding the anastomotic leak, the investigations again, don't wait for the anastomosis or don't wait for the signs of peritonism to build up. Go ahead for a CT scan. When there is an anastomotic leak, the CT scan can pick it up. And if there is the easiest way or the other important thing which we can do is do a gastrographic enema with the CT scan will give you a clear picture whether the patient has got anastomotic leak. And again, depends on the situation. If the patient is stable, not septic, not unwell. If the patient is not unwell, anastomotic leak can be managed conservatively. And there is something which is coming up, cytosponge or spitosponge, which is still helpful in the anastomotic leak. In the exams, it may be tested. You may be tested with the cytosponge technique. Not sure about the recent past. I think there are chances of there is a chance of testing this cytosponge. Cytosponge, if you Google it, it is highly useful in anastomotic leak, especially in rectal cancers and the esophageal perforations after the esophageal Ivor-Lewis esophagectomies. So cytosponge can be used. Anastomotic leak usually managed conservatively. Cytosponge, if things are not settling down with all these things, the patient is peritonitic, free fluid in the abdomen, guarding rigidity, not responding to antibiotics, and conservative management, then the anastomosis has to be taken down with a proximal in colostomy area or ileostomy. So next comes the hemorrhage, and everyone knows the lower GI bleed. So hemorrhage is nothing but lower GI bleed. How are you going to manage the lower GI bleed? Make sure these are the causes of lower GI bleed. So one thing which I want to mention here is diverticular bleed is more common in the elderly. You consider this as a diverticulum in the colon. Consider this as a diverticulum in the colon. And why there is a diverticular bleed? Usually there is a blood vessel which is entering into the diverticulum at this point, and this is the reason for the diverticular bleed. Most of the diverticulum is around a blood vessel, so highly likely to have a diverticular bleed. Other causes of lower GI bleed are neoplastic inflammatory ischemic colitis, angioectasias, post-polypectomies, and post-surgeries. So these are the causes of lower GI bleed, and usually they are managed as per the BHG guidelines. BHG guidelines says that uh, assess the patient, assess the patient's shock index. And if you have a look at this, what exactly is this? This is shock index. I can zoom this for you guys. So shock index is nothing but heart rate divided by systolic blood pressure. So if this indirectly, this is nothing but if the patient has got tachycardia and hypotension, your shock index is going to be high. So tachycardia and hypotension, shock index is high, then go for a CT angiogram. You will know where exactly is the patient bleeding. Is this patient bleeding in the large intestine? Is this patient bleeding in the small intestine? So you'll know where exactly is the patient bleeding, and then you can either embolize, CT guided embolization at the same time, or IR guided embolization at the same time, or endoscopically you can occlude the block the bleeding or clip the bleeding. If it is not successful, then the patient has to have a emergency surgery, either selective colectomy or selective segmental colectomy. The patient is stable enough, you make sure that you calculate the risk. That's something called as Auckland score. Auckland score, if you go to the BSG guidelines for lower GI bleed, you'll see what is Auckland score. If it is a minor, you can discharge the patient. Any lower GI bleed, if it is a diverticular bleed, make sure that these patients are stopped with the anticoagulants. Most of the patients will be in apixaban, clopidogrel, and if there is an ongoing bleed, don't discharge them, admit the patient. And Auckland score is going to help you whether to discharge the patient or whether to admit the patient. If the Auckland score is, I'm not sure about the scores. If it is 8, I think it's 8. If it is more than 8, then admit the patient. I'm not sure. So admit the patient and do a lower GI colonoscopy, treat as per the need. And if it is a minor bleed, you can discharge this patient. So this will be tested extensively. These areas will be tested extensively. CT angiogram, what is the evidence says about the CT angiogram, mesenteric angiogram? CT angiogram can pick up at least 0.5 ml of blood per minute. Mesenteric angiogram can pick up, I think it is 0.3, and technetium M99 scan can pick up 0.1 ml per minute of bleed. So these are the 3 areas. So highly sensitive is high pickup rate is from technetium M99. Exactly, cost effectiveness. CT angio can definitely pick up 0.5 ml of blood per minute. So usually go for a CT angiogram. The BSG guidelines says CT angiogram. So go for the CT angiogram. This is just for a MCQ purpose. Indication and indication for emergency or urgent surgery is when there is an ongoing bleed with the 6 units of transfusion, more than 6 units of transfusion, and ongoing bleed, patient's hemodynamically unstable, go for a segmental resection. If you want to know where exactly is the point of bleeding, you can do an intraoperative colonoscopy and proceed further. This is how hemorrhage is treated. The other causes, the next most important colonic emergency is ischemic colitis. Ischemic colitis can be non-occlusive or occlusive. If it is a non-occlusive, the reasons for non-occlusive colonic ischemia are hypotension, hypovolemia. In other words, when there is a decreased blood supply or poor blood supply to the mucosa, these are the chances, these are the reasons for ischemic colitis. And there are other causes like drugs, like vasopressors, cocaine, antiarrhythmic, especially when the patient is septic, noradrenaline is going to worsen the problem. Uh, Exams, they may ask, patient is on noradrenaline, sepsis, abdominal pain, what do you think of, can be ischemic colitis. Again, you just treat the cause, just make sure that the patient is getting rid of hypotension, hypovolemia, arrest the bleeding, patients get settled down, and there's no reason this patient needs to go to theater. Treat the patient conservatively. Uh, this is how the patients are uh, classified as per the endoscopy: mild ischemic colitis, moderate ischemic colitis, and severe ischemic colitis. When there's a frank necrosis and circumferential involvement of the large bowel, then it is severe ischemic colitis. Only severe ischemic colitis may need surgery. Mild and moderate are usually managed conservatively. Even long-term management of long-term non-operative management can help these patients um, to not to go for a surgery. Mild, just pale mucosa edematous, and small ulcerations, epithelial hemorrhages. Moderate ischemic colitis, dusky mucosa, submucosal hemorrhage, and hemorrhagic ulcerations. As I said, so this is how these are the areas. I think you can just have a quick look. Laboratory tests, lab investigation wise, patients greater than white cells greater than 15, acidosis. Uh, all these patients should have CT scan. The CT will give you the colonic wall thickening and the perfusion. And gold standard, again, ischemic colitis, it's colonoscopy. So you do a colonoscopy, classify the type of ischemic colitis, and then, as I said, mild and moderate, mild, observation, supportive care, and moderate, again, intravenous fluid, antibiotics, surgical if it is needed, surgery if it is needed. If it moderate, can jump into severe at any time. And this picture is there in the internet. You can just download it. This gives you a good view of what is there. Severe, usually patient may need surgery. Sorry, guys. All right, and this is a nice guideline. You can download this in the stuffs which can be useful for the exams. Nice guidelines for diverticular disease management. A small guideline. I think it is just a 10-page. It's easy to read. That will be definitely helpful. 2019 nice guideline. You can Google it. You will get it, and you can download it from the internet. And this is these are the just pictures to show you guys for the management plan. If there is the controversial areas, try to check the nice guidelines. They will have a clear idea of what exactly is you have to answer in the exams. And for people with suspected acute diverticulitis, make sure that these patients are started with antibiotics for 2 days, and these patients need CT scan in 24 hours. If you don't have a CT, if you're not planning for a CT, if the patient is contraindicated for CT scan, then go for an MRI or a non-contrast. First is non-contrast CT. Go for an MRI if it is not possible for a CT scan at all, or at the end it is ultrasound scan. And if there is a raised inflammatory markers, suspected diverticular disease, and this picture will be tested in the exam. This is not a gastric dilatation. This is not a sigmoid volvulus. This is cecal dilatation. How to differentiate a cecal volvulus from a sigmoid volvulus? Sigmoid volvulus, the dilated coffee bean appearance starts from the left iliac fossa. You can see here, it is not from, this is not this picture. This is the picture here. And you can see the walls here. And this is the, again, large bowel. And I could not make out any stomach. Most of the time, these pictures, this is a cecal volvulus. And cecal volvulus, it usually starts from this side and ascends this way. So this is how the cecal valvulus appears. Rest of the symptoms and signs will be same. And this is a perforated diverticular abscess. You can see the collection here with some air particles, uh, gas particles around the inside the collection. And again, this will be tested again. And you can see a diverticulum. This is the diverticulum. And there is a clipper which is put around the diverticular bleed. You can see this. There's a bleed here. There's a bleed here. There's a bleed with a clip with a metal clip put on the diverticular bleed. So tips for answering the questions in the exam, in the part 1 exams. I'm just going to unmute, guys. I don't know how many people are there. If anyone wants to unmute and ask questions, I'm happy to answer regarding the question and answers for the exam tips. I'm not going to just go for things. So let me tell you a few tips for colonic emergencies when you answer the questions. Don't just jump and answer the questions. What is the treatment for this this thing? For example, if the patient has got cecal valvulus, what is the next line of management? You show the X-ray. What is the next line of management? Until otherwise, if there is no specific mention about the resuscitative measures, don't mention as right hemicolectomy. If you have any resuscitative measures, then think of it before you answer the questions. So make sure that you answer the question in a systematic way. That will help you to answer. So don't jump into the surgical management. Otherwise, go step by step. If there is no bloods available, if there is no investigation available, try to do that investigation rather than jumping into the management or the surgery. Any doubts, anything? I'm happy to answer anything.
Yes, excuse me, just I have one questions regarding the, you hear me well?
Yeah, go ahead.
The self-expanding metallic stent in the diverticular structure and other benign colonic obstruction. Many surgeons said that the stent carry high risk of perforation and migration, and they don't like. Is it adopted in the guideline to put
I think I said it clearly. The stent is bridging for the surgery. If you put in a stent for a benign thing, the patient should have the procedure in the same sitting or in 7 days time. Is it?
Okay, thank you.
So there is no role for putting a stent and discharging the patient. If you put in a stent, you are converting the emergency to an elective or semi-elective. That's it. There is no role for putting in a stent and waiting for years together or months together or weeks together. You're going to do this. In malignancy, it is optional. It all depends. In malignancy, in malignancy, if you're asked, are you going to put in a stent? It used to be if the patient is going to be palliated. There is no, like, for example, I think it's a bit noisy. Can someone?
Okay, sorry.
Sorry. Okay. In exams, if there is a neoplasm with the option of stent, the question is: are you going to put in a stent for to palliate the patient, or are you going to put the stent for an elective procedure? If you're going to put in a patient for elective procedure, do it on the same, like you are going to put in the stent today, and within 7 days you are going to do the operation. And if it is a palliation, yes, you can put in the stent and just leave it. You are not going to do operation. The patient is going to die somewhere anyhow. So you can just put in the stent and just leave it there. And if you're going to give a chemotherapy for a patient who has a stent, I don't think that is an option. It's an extensive topic. You can, I think I've not given my email ID. I think I can give you guys my email ID. You can email if you want. If you have any doubts, I'm happy to uh, give more things. And I think you guys will be having my phone number. My email is varun.arunagiri@wales.nhs.uk. So can email whatever the uh, needs, tips. The most important thing in the exams is, with the scenario, take the scenario as a real lifetime scenario, and don't jump to answer the surgical option at the first instinct. Try to assess the patient, what the patient needs, like correction of electrolytes, correction of resuscitating the patients, investigations, and then go for the surgical management. They can assess you at any level, like investigations. They may give you ultrasound, they may give you CT scan, which will be the best option. Like for example, if they ask you there is a lower GA bleed, the patient is comfortable, just a minor bleed, what are you going to do? If you see the BSG guidelines, you can discharge the patient. And if the patient is unstable, they will give you the both option. They will give you the option of colonoscopy, and also they will give you the option of CT angiogram. The recent BSG guidelines 2019 has changed the previous guidelines. Previously, it was colonoscopy, and now they say that there's no role for colonoscopy in an unstable patient. Go for a CT angiogram, which decreases multiple steps. So now the answer will be CT angiogram rather than a colonoscopy. And always the exam test, the recent guidelines changes. If you go to the BSG guidelines, you will be tested on these guidelines rather than the books and the standard books. Any doubts? Do you mind? Shall I wind off? Thank you, guys. Any doubts or anything, you can ask me, or else, yeah, Moses, go ahead, please. Moses Chak Joachim.
Can you hear me, Varun?
Yeah, yeah.
This is Moses. Hi, Moses Amar.
Yeah, Amar. Sorry. I know that you. I thought something. Yes, Amar. Go ahead.
Very good presentation, but I was just wanting to talk about two main things. One is like in case of toxic megacolon, especially especially in case of ulcerative colitis, you'll be tested a lot on ulcerative colitis. Actually, especially in toxic megacolon, there is something called as Travis criteria, like Oxford criteria. That is, they ask a lot of questions on that. That says that if you have bowel movements like more than 8 times per day, there is a high risk that the patient might need a colectomy, like more than 80% chance of needing a colectomy. So these are guidelines which the examiners like to stress on that, and the questions are framed in such a way that they ask these questions in the exam. So remember that that's a very common criteria called the Travis criteria or Oxford criteria, which says if the patient is on steroids and if you're managing for toxic megacolon, if he has bowel movements more than eight bowel movements per day, there is on day 3 or day 8, there is an 80% chance that he will land up with a colectomy. And similarly, if you can say if the patient has got a bowel movement between 3 to 8, and if he has a CRP of more than 45, there's a high chance he'll end up with a colectomy. So in the exam, how they will ask you is a patient on steroids on post-op day 8, on day 7 after steroids, has got bowel movements of more than 8 times per day. What are your options? And one of the options will be a colectomy. So it can work either way. So just be careful. Like you have these one or two, criteria like this, which you have to be careful. So in that condition, you shouldn't say like, I'll give him IV fluids and, go slowly. So
Yeah.
that's one I would like to say. And the second is that anastomotic leak, like you mentioned about the cytosponge and the endosponge. That's a very good thing. They ask questions based on that also. A lot of questions based on that. So try to endosponge is always an option if the patient is hemodynamically stable. IR drainage externally if there's a collection externally to the bowel. with an endosponge internally to drain. The endosponge is basically a vacuum. It just pulls out all the pus, tries to get out the pus, isn't it? And it helps. So that's how it works. So that's another thing of anastomotic leak that they might ask. So, and the other one is lower GI bleed. I was one thing to say on that. The lower GI bleed, especially know about why the Auckland criteria is used. The Auckland criteria is basically you have patients in the night who come. You don't know whether to send them home or to keep them for investigations. So the Auckland criteria has basically clinical information where you get a score of, it's got about 35 points, and you get a score of more than 8, which means that the patient has to stay and get it as an inpatient. A score of less than 8, you send the patient home and get it as an outpatient. And another thing where they test you a lot is in lower GI bleed, especially after you have, so like for example, you've done a colonoscopy, you've done a gastroscopy, you have not found a source of bleed. Well, where else will you look for? So you should look for small bowel bleed and things like that. So that is a very common area of testing. Another one is in lower GI bleed is, for example, they give you scenarios like a 80-year-old man has come, known case of diverticular disease. Flexible sigmoidoscopy shows no evidence of bleeding. So where would be the most likely cause of bleed? Questions like that. So angiodysplasia is the most common, second most common cause. So questions like that. So they can ask you questions like that. So be prepared for lower GI bleed, toxic megacolon, anastomotic leak. In colorectal emergencies, these three components are very, I mean, of course, everything is important, but try to concentrate on these three. And especially because that's where they try to ask most of the questions in colorectal emergencies. But that's it. I just wanted to tell those things.
This is actually basically this is extremely hot topic, especially when it comes to FRCS. I think this is extremely hot topic, and you have to have uh, all kind of options, all kind of knowledge, extreme good knowledge, both in part one and part two. Any doubts or anything? Just to more introduce Amar. Amar has done his both FRCS International and JCIE. So nice, nice. Thanks, Amar. Thanks for joining. I didn't realize that you were here. Any doubts? Shall we wind off? Thank you, guys. Thanks for joining, and hopefully, if there is any need for any further topics, just put it in the uh, uh, WhatsApp group. We'll try to make some presentations. Thank you all.